Greetings from eMedi News and HCFI Foundation of India. Welcome to the show Chat with Dr. KK. And today we will have with us Dr. Prakash C. Didwania, who is a clinical professor and chief of cardiology at University of California, San Francisco. He is also a clinical professor at Stanford University. Thanks and welcome to our show. We have been watching you for over a decade, listening to you and seeing your interest changing from subject to subject. And now your passion today is on preventive cardiology.
Yes, indeed.
And your second passion is optimal medical therapy.
Yeah.
We're going to concentrate on both the issues.
Okay.
When it comes to preventive cardiology, there has to be something wrong in India, because in our mythology, when we talk about Treta Yuga and Dwapar Yuga, in Ram Rajya and in Krishna Rajya, except for Raja Dashrath, there is no mention of coronary artery disease.
Right.
If I see the rulers of today in India, the member of parliament, the politicians,
they all have
the prime minister, the president, the ministers, you'll find a large number of them have either a coronary artery disease, bypass surgery has been done. But in our ancient rulers, except for Raja Dashrath, there is no mention of coronary artery disease. That means there is something. People say that being an Indian is a risk factor. At that time also they were Indians.
But our lifestyle has changed dramatically now.
So
in those days, our rulers or Raja, Maharaja, jo bhi bole hain, they used to be physically active. They used to go hunting. They will be very active within their palace even. They will not be sitting on their throne. They will be going out in the garden, walking, talking to people and all that. Today, politicians, I don't want to be specific to anybody, they're mostly sitting in their chamber or they're going to parties, and they also have, in addition to that, they have a lot of stress level. In those
do you
days,
think that metabolic syndrome, which was not there before, except for Lord Ganesh,
Right,
who has been mentioned as a with a pot belly, we have not seen pot belly in any of our mythological people.
Right.
So do you think that is that the recent concept of so-called insulin resistance is the new epidemic which is leading to coronary artery disease?
I wrote about it actually before it became popular even in America. I had a special issue of American Journal of Medicine on cardiovascular metabolic syndrome in 1998. The metabolic syndrome, as we see in India today, is really a disease of westernized lifestyle. It's the westernized diet, it's lack of physical exercise, and yet consuming calories that are beyond what our body can. So it's what was defined long time ago, caloric excess in far in excess of the demand.
So most of you people say that being an Indian is a risk factor.
Well, I don't know whether being an Indian itself is only a risk factor, but what we are saying is that today the disease prevalence is so much higher in India.
Let me complete my question. If I take that hypothesis that being an Indian is a risk factor, then my mythological era lifestyle was preventing me, because the genes are the same, was preventing me from getting a heart attack. And the Western culture, with the genes we have, is putting me into a risk of heart disease much more than Americans.
Well, there is this hypothesis, which is never 100% proven, of thrifty gene hypothesis. And the thrifty gene hypothesis teleologically goes to the fact that even in those days when our rulers and other people were there, in India there used to be cyclical famines. And if you remember the ethics of our old rulers, if the regular people cannot eat enough, then they also, along with them, used to fast. This sort of cyclical famines produce this so-called thrifty gene in our body, essentially storing energy for the hard times. And this phenomenon, as you know, has been going on until the canal system came out. And this was going on for centuries. And this thrifty gene now is malfunctioning. There is no need for thrifty gene. There is now gluttony. Everybody is eating more than what they need. And this thrifty gene malfunction now, instead of storing, it really is over-storing the calories. And this is what leads to fatty liver. This is what leads to deposition of fat in the visceral tissue, which then has become an endocrine factory. And that's what causes the metabolic syndrome.
I'll give you one more hypothetical situation. And that hypothesis is that refined carbs, white sugar, white rice, and white maida, is one of the factors for
Yes, indeed.
hyperinsulinemia, insulin resistance, metabolic syndrome.
Yes, absolutely.
In our mythology, there was a rule that you will fast once in a week, you will extra fast once in a month,
Right.
then you will fast 9 days each on Navratras. That means 80 days in a year you will fast.
Right.
And the fast that meant was no cereals, no
Right.
carbohydrates.
Correct.
That means carbohydrate fast was recommended in our mythology 80 days in a year. Was it preventing so-called metabolic syndrome?
It probably was, and when people today, when they talk about, oh, we are still fasting, they're not fasting. They eat 10 times a day.
That is feast, fast, and
Yeah,
feast.
exactly.
That's not a fast.
So I agree with you. I think the lifestyle was such, a lot of physical activity, these kind of fasting,
And no cereals,
no cereals,
80 days in a year.
and even not just no cereal. We used to eat a lot of pulses, lot of cereals that were whole rather than eating these refined carbohydrates. Maida was rarely used in old times. I remember even in my own lifetime, 50 years ago, maida was not heard of.
Absolutely.
Yeah. So I think, and of course, the whole wheat, as we know today in the diet as well, has a lot more properties, has proper fiber, and fiber has been shown, high fiber diet has been shown to reduce the risk of diabetes and also lipids as well.
When I teach my patients, I've created a formula of 80 and I would like your comments on it.
Okay.
My formula of 80 is that keep your lower blood pressure, fasting sugar, abdominal circumference, LDL cholesterol, and resting heart rate, preferably all below 80.
I think that's
For
all.
that, walk 80 minutes a day. 80 minutes a week should be brisk walking. And brisk walking means minimum 80 steps in a minute. Eat less, not more than 80 grams of caloric food or 80 ml of caloric liquid at a time. Fast 80 days in a year. That means do not take cereals 80 days in a year. Do not take alcohol if you take less than 80 ml or less than 80 grams in a week. Do not smoke or you will end up with the 80,000 rupees stent. Do not sit in an atmosphere with more than 80 decibels of noise pollution that can cause high blood pressure. Do 80 cycles of pranayama in a day. Give 80 minutes to yourself. And if you are a heart patient, ask your doctor for 80 milligram of aspirin and 80 milligram of atorvastatin or any statin.
I think that's a very good.
That's a way of.
That's a very good formula. But let me ask you, how many of your patients are able to do all of this? That's the problem.
Even if you see, what I do with my patients is, all my patients, I make them come to me for 3 months every day in the morning from 7 to 9. They have to listen to me in a discipline program. I have a completely disciplined program, and in 3 months, 90% of them, then they follow it up.
They follow it up.
At 5 years, I have 70 to 80% of them who are following it up.
Well,
But for that, I need them 3 months with me, 2 hours every day.
Well, then I must compliment you. You are one of the most successful person who has been able to maintain the lifestyle, therapeutic lifestyle change, because this is a drastic change in their lifestyle, and if they're able to maintain it, that's definitely would work.
Okay, when I talk to the optimal medical therapy, when we talk about the Courage trial and we talk about optimal medical therapy in chronic stable angina, what is the current stand today for angina? If a patient is not in emergency, no ACS.
Current stance, and this is what we discussed this morning in one of the plenary session, is for patients who have stable angina or who simply have what happens in India quite frequently, just a positive treadmill, which is done for just checkup and all that. There's absolutely no reason, rhyme, or evidence that they need to undergo any kind of revascularization. That is an absolute rubbish nonsense. That is something that is wasting a lot of money and creating an abnormal milieu in their coronary vascular tree. That's only going to create more problems. There is absolutely no evidence that doing any angioplasty, even in patients who have multivessel disease or even bypass, in today's day and age, I'm not even sure that I agree with our own data and others, the left main disease need to be revascularized, because those are old data. Today we can stabilize the plaque even in left main disease. And it's the unstable plaque that causes myocardial infarction, which then subsequently lead to death, sudden death, what have you.
To find out whether the plaque is unstable, one is symptoms. The second is,
you don't need to do anything to it.
No,
if anybody has disease, you can assume that they have multiple unstable plaque. So I assume every one of my patients has unstable plaque. I treat every patient as a time bomb once they have risk factors. And I treat every patient aggressively, bringing their LDL down as much as I can. If they already have established disease, their LDL should be somewhere between 50 to 70. They should all be on aspirin, like your own 80 rule. So they should be on 75, 80 milligram of aspirin. In addition to that, their blood pressure should be reasonably controlled. I have become a firm believer in the last 6 months to a year with all the meta-analysis and review of the data that we don't need to drastically lower blood pressure. I think having blood pressure somewhere to less than 140 over 85 or 90 is sufficient enough, because there is the U-shaped or sort of a J-shaped curve for blood pressure. And I think if they have diabetes, probably with lifestyle change, such as what you suggested, or with drugs that don't have adverse effects, such as metformin, but have some DPP-4 inhibitors, controlling their glucose, avoiding sulfonylurea and insulin as much as one can.
So failure of medical treatment to provide wanted quality of life is the indication for intervention.
Well, still I'm not sure that that's the indication, but then you might have to do it if they are having a lot of symptoms.
No, failure of medical treatment.
Yeah, but
to provide
failure defined by what? They have to have symptoms.
Okay.
The only thing that revascularization does is improve symptoms.
That's
nothing else.
Nothing else.
So even if they fail, they might be at a risk of having myocardial infarction, but I'm not sure that I can reduce it by doing the most comprehensive, complete revascularization. I cannot do it. I mean, there is some suggestion that those who have had life-threatening arrhythmias, perhaps in them I can prevent certain deaths. That's about the only evidence there is.
I'm aware of two of our politicians. Mm-hmm. Both of them, the one have got 3 procedures in 12 years,
Mm-hmm. Yeah.
2 angioplasties and 1 surgery. The another one had 4 procedures in 12 years, 2 surgeries and 2 angioplasties.
Yeah.
The public perception is that angioplasty and bypass doesn't last more than 4, 5, 6 years.
Yeah. Well,
then why not postpone them as long as possible?
Yeah, why not postpone them? And I think those politicians and other people alike might be thinking, oh, because I got that procedure, I'm leaving. No, not only, first of all, false perception that I'm okay, now I can go out and drink and do whatever and eat whatever. That's false security. But in addition to that, often people cite these examples. But because he got this procedure by such and such doctor, that's why he's leaving. That's nonsense. There is no comparative data showing that. Actually, data is on the other side, that if he didn't get the procedure and had optimal medical therapy with all the things we talked about, that he would probably do better than what he's doing. First of all, avoiding any procedures, avoiding all the unnecessary testing that goes with the angioplasty, because once you have angioplasty, you unnecessarily go through scintigraphic studies and echocardiographic studies and all that. I mean, I think, I hate to call it as a monetary gain for my colleagues, but keeping that aside, as far as the patient benefit is concerned, I really don't see any.
Most of the doctors in India, the budding doctors, are shifting to interventional cardiology because of monetary benefits.
Yeah.
Because they feel there is more money and...
But that's changing in the United States.
So what is the economy of preventive cardiology in the United States?
In the United States, people are now switching more to things like preventive cardiology, heart failure, electrophysiologic areas and all that, because
in preventive cardiology, is it more paying in US?
It will be with the Obamacare now. Yes, it will be paying.
What will be the change in Obamacare?
Well, Obamacare will regularly pay for preventive strategy. For example, regular screening of lipids and treadmill, etc. that is done, and then subsequently for what we call cognitive medicine, in which like interaction with the patient.
Will that be? Will the counseling sessions be paid?
Yes, that will be paid.
And will that be enough for young budding doctors to shift as a monetary benefit?
That I can't tell. I mean, right now, unfortunately, we have a large fellowship program, and we have the same quantity that you are mentioning, because everybody thinks that they are incomplete if they don't know how to do intervention. I was doing intervention 35 years ago. I never felt more complete.
So in India, if you are an interventional cardiologist, you are A grade, and if you don't know how to do an intervention, you are a B grade.
That's very unfortunate. That's very unfortunate. I mean, that's because people have thought that only if they can push catheter that they are cardiologists, otherwise they are not cardiologists. That's very unfortunate. It takes a great deal of knowledge and it takes a great deal of thought process to be a good all-around cardiologist. It does not take that much effort to be a good plumber. A plumber does not need to be educated.
Absolutely. If Obama calls you and makes you the head to develop a cardiology program in India,
yes,
or in the third world countries,
yes,
what will you do?
Well, I would definitely implement public health measures first. What India needs today is awareness of the public. Public doesn't know. This morning I was talking to Professor Manchanda. He said that he was treating a minister, and the minister didn't even, he was undergoing treatment by someone, I don't know the name, and the minister, when Dr. Manchanda told him that, how are you eating eggs? 2 eggs will have 600 milligram of cholesterol. He said, nobody told me. This is what is happening to our elites. You can imagine what the lay public knows about it. So I think, and we should really incorporate, since public in India is very much influenced by cricket players or Bollywood stars, we should incorporate some of them and have them campaign for healthier lifestyle measures, etc.
So when it comes to campaign, in India, 25 lakh people die every year because of cardiac arrest.
Minimum.
18 lakhs of them die before reaching the hospital.
Right.
The answer lies in training public in hands-only CPR. And we have a program called CPR 10 that within 10 minutes of death, earlier the better.
Sure.
For the next 10 minutes at least, compress the center of the chest with a speed of 10 into 10, that is 100 per minute.
Right.
Do you feel that every school
like that,
education like that?
Absolutely. Anything like that we can do, and it doesn't need to be perfect. We don't need to always say that it has to be, everybody needs to have basic CPR training. Anything like that would be only helpful. And I think once we start doing more, we can be probably more organized, more systematic. But any effort like that, for example, there was a question in the session I was lecturing today. They said, should we do a ApoB and ApoA lipoprotein? I said, no, absolutely rubbish. We don't need to do it. We can't even, right now, 80% of the patients here don't even know what their LDL is, and they don't know what it means. So we should just do basic things. We don't need to make life more complicated.
Now your passion has been a medical profession.
Yes.
I know you belong to a doctor's family. And I also know that your children has not chosen to be a medical field. They have chosen to be either attorney or in a musician, in an artist. If to any circumstance you were not a doctor, what you would have been as a passion? Do you have any other passion? That means you have any other hobby?
Well, I have multiple hobbies, but hobbies are different than what I want to do in life. But I mean, first of all, I never thought of anything other than being a doctor. From the time I was a child, because my father in those days used to have practice at home. So people would come to see him. And when I used to see some of the people in Rajasthan put their turban in his feet,
you decided that nothing else.
I thought nothing could be more noble than that, and the confidence they had in him. I think if for some reason or other I could not become a doctor, I would still be probably trying to do something in the healthcare field, policy making perhaps, because that has been my passion since the time I was in medical
But do you
school.
have your comments about other systems of medicine? Ayurveda, homeopathy.
Oh, I think these are all complementary, what I call them complementary. Ayurveda is an excellent system and properly done. My uncle was a very famous Ayurveda in Rajasthan. He was blind and he really took care of lots of people who would come to him, and I used to admire whether he used behavioral modification, whether he used his common sense and just what knowledge he had, but his patient used to feel quite well afterwards. And this is what today we call naturopathy. Ayurveda is 50% of Ayurveda is naturopathy, using natural ingredients which have been shown over time, like using turmeric for things like, and we know today people take haldi tablet, Karela and all that for prevention of diabetes. It has been established for a long time. So I think Ayurveda is very good. I think our other systems that are homeopathic, I'm not as knowledgeable about them, but I think in certain diseases, skin diseases and others, homeopathic might also work very well. But I mean, my knowledge is confined to
allopathic system.
So
So what Dr. Prakash Didwania says is that if he was not a doctor, probably he would have gone into policy and still connected to healthcare. He never thought of not being a doctor or not being associated with the healthcare, and he thought that the noblest profession is a medical profession. And if that is the spirit of people like him, and that should be the spirit of the younger generation, that the medical profession is still a medical profession. Dr. Didwania is very clear that no interventions unless they are a must. If a patient is asymptomatic, don't touch. Don't touch a sleeping lion. If you touch him, he will backfire you. That's all for today. We thank our guest, Dr. Didwania.
One additional thing I'd like to add there, be honest with your patients. If you decide to do intervention, tell your patient that it is not going to prevent heart attack and it's not going to prevent them from dying. If you tell that, 80% of the patient will not undergo that intervention.
So,
Dr.
Dr. Ridwania very clearly says is, imagine yourself as a patient, and if you are going to talk about that, if you are going to say, go and do angioplasty in me, then only advise your patient to go for angioplasty. Otherwise, go for